Most of you know me, I'm R. Panaccione from the University of Calgary. So this is just the disclaimer for Sandoz, which I'll allow you to read. We want to share that current knowledge on how to choose the right treatment for the right patient. Now, that is probably the hardest thing to do in inflammatory bowel disease, right? And you'll hear me say this over and over again. If everyone knew how to, if this was that easy, then everyone would be an expert. So we're going to talk about some maybe practical recommendations on how to optimize treatment and highlight the important, really from the patient's perspective in achieving some of the therapeutic goals. So I'm going to talk about IBD subgroups. So a lot of this is going to be practical in nature and describe how I choose for, potentially for individual patients, and I think the steps that I go through, and then we will leave time for question and answers. So I show this slide quite often whenever I give a talk, and now it doesn't matter if I give a talk to gastroenterologists, now I give talks to rheumatologists, respirologists, any area of in sort of biologic therapy, because I was there in the beginning when biologics were introduced. I was doing my IBD fellowship at the Mayo Clinic, and that was, it'll be over 20 years ago, and infliximab was introduced in the United States. And we thought that that was going to open this floodgate of new therapies that we can use for our patients. And as most of you know, by looking at this timeline, it almost took 15 years before we had a second agent. And I think the promise was that if we had multiple agents, that it would be best for our patients, and then we would have all of these strategies and we could segment the patients into different populations. And unfortunately, whether you're looking at Crohn's disease or ulcerative colitis, in the era where we have multiple therapies, we still struggle with trying to choose what the right therapy is. And part of it, as most of you know, and this is something I think that both Iris and I probably struggle with a little bit coming from IBD centers, is that IBD is very complex. It's not as simple as we think, not only in making treatment decisions, but the variety of patients that you're going to see. And so at these conferences, we talk about multidisciplinary team, we talk about different imaging techniques, we talk about therapeutic drug monitoring, but we recognize that in individual centers around the world, some of this is not available. And so we always need to remember that when we're up here on stage and we talk to different sort of colleagues around the world, that you have to take what we say and put it into the context of what you are able to do within your own clinic. So there's everyday challenges. So one of the things that I think we always need to anchor in thinking about treating the disease is think about the concepts beyond the drugs themselves. One of the things that I think may differentiate success with therapy has nothing to do with the drugs. I always say it's not like at the University of Calgary we have supercharged infliximab or magical adalimumab, right? And so I think in this really sort of highlights some of the concepts. Certainly in the environment that you're in, you want to be able to make the diagnosis quickly and accurately. You want to be able to assess disease severity, and we'll talk more about that, and determine what that prognosis is. Select that initial therapy and to induce and maintain remission, and the speed at which you do that I think is important. And that not only involves the access to drugs, but it involves the confidence of the physician, as we'll probably highlight later today, as well as the education of the patient. And all of that takes time. We want to adjust therapies to achieve a target, which you heard about yesterday, and try to modify the long-term outcomes of the disease. So how can we do this? So this is about really giving you some practical advice on sort of some of the subgroups. I think that, again, I've already alluded to, it's great that we have the drugs, but it's really about the strategies. And the strategies will be outlined in sort of 4 different important pillars, and that strategy has to be for the right patient at the right time. The one thing that we would want, and Iris probably will agree with this, is, or what everyone wants, is this precision medicine, where you have a biomarker for an individual patient and you can do a test, and that test will tell you what the right drug is for the individual patient. Every single company that is in the area of inflammatory bowel disease is trying to find that magical biomarker. And research centers such as Iris's are also looking at that outside of the pharmaceutical industry. And unfortunately, the signals that have been available either haven't been sustained or haven't been replicated, and or are not commercially available or practical at this point. So again, we're left with making clinical decisions rather than this precision medicine decision. And so when we look at this, I think you need to take a holistic approach. You need to remember your roots as a physician and why you went into medicine. And every time a patient comes to you, you have to ask your questions that are on this slide. Who is the individual patient? And that question includes not only what their disease is, but where are they in the stage of their life? What are their priorities? What do they value when they choose therapies? Which is very different for individual patients. There is the disease state. What is their risk of disease progression? That discussion, and you'll see that in cases, I think, throughout the day today, is we always talk about treatment targets, but remember that when we talk about treatment targets, we speak to it as if everyone will want to advance therapy and achieve mucosal healing for their disease, and when they feel well, they'll still make that decision. And we know in clinical practice that's not the case, right? So the treatment targets for individual patients, it's not us who choose the target. It's really, we educate the patient about what that target should be, but the patient chooses the target, because when you're chasing that target, the patient needs to make the decision to change therapy. So we can't lose that. What's the likelihood that they can have an adverse event from therapy? And this is very, very important when we talk about subgroups, because we know within the scope of our clinical practice, based on age and comorbidities, that the adverse event profile, depending on the different classes of drugs, may be somewhat different. So the example would really be, we believe that all biologics, for example, are generally safe, right? But we know that some of the newer biologics carry less risk for serious infections than our old friends, the anti-TNFs. That being said, when you talk about therapy to individual patients and they choose and they think about safety, they don't always think about the shopping list of safety, meaning I have to tell you about infections, serious infections, malignancy, et cetera, because when patients choose therapy, sometimes they choose therapy based on the experience of the physician or how long the drug has been around. So you probably experienced this from the perspective of, when a new drug is introduced, at least in Canada, and I start to talk to patients about this, some of them say, well, how often have you used this drug? Maybe it's my mistake because I say, oh, there is a new drug, right? And sometimes new drugs, people do not want to play always with the shiny new toys. And then the next two things I think are becoming increasingly important as we have different mechanisms of action, which is trying to remember that IBD is a systemic disease and carries with it extraintestinal manifestations and other immune-associated diseases. And so we need to be better clinicians today, even though we have better drugs, than we were even 10 years ago, because at least in my clinic, this influences things. So you've seen this traditional step-up approach, which I think is very antiquated. So we've really moved away from sort of having patients need to sort of earn their way to biologic therapy. And this is just an example of why, many of us have abandoned this step-up approach, because even when in patients who are on conventional therapy, and this is the UC CARE study, is that there's this misperception, I think, of patients on conventional therapy of what well could be. And so this is from Laurent in about 150 patients with ulcerative colitis. And the disturbing thing here is if you just look at, and we're not talking about biomarkers or anything, if you just look at clinical symptoms related to ulcerative colitis, the number of daily stools or the rectal bleeding, right? This is on either 5-ASA, on prednisone and or an immunosuppressant. You can see that like less than half of the patients are actually normal, as we would consider them in remission by parameters of stool frequency or rectal bleeding. More disturbing is if you look at patients who are having greater than 4 or 5 stools a day or noticing a significant amount of blood. This is almost a quarter of the patient population on conventional therapy. So what this tells me is, perhaps not only that conventional therapies are not doing what they should be doing, but perhaps we're not educating our patients so that they seek help when they continue to have symptoms. And as you know, that our treatment goals have changed over time, and this has really happened because we do have drugs that can achieve some of these endpoints, such as mucosal healing or the combination of mucosal healing and symptomatic improvement. So this is all anyone ever needs to know about IBD. These are, if you can get these 4 things right, I tell the IBD fellows, I said, I always say, I don't know why you're here for a year, right? Because these are the only 4 things that you need to know. If you do this systematically in every patient that you see, right, you will be an IBD expert. And I said, I can teach you that in, well, not 45 minutes, but I could probably teach you that in about 1 to 3 months. So, so we stratify risk, and most of you know what that risk is. We talk to the patients and set treatment goals and agree on what those treatment goals are. We select treatment, and that's what I'm going to concentrate on, and then we monitor progress, and Iris will talk about that a little bit later. So selecting treatment, I think these are the things that we need to think about in the individual cases and the individual patient, right? How important is it in that patient that's in front of you when you're making the decision that you have a fast-acting therapy, right? One of the things that I think is important to think about when it comes to this is you will see a whole bunch of subgroup analysis from different studies that says, oh, look, the drug differentiates from placebo by 2 or 3 days. This is a chronic disease, right? The patients, if you expect the drug to be different in 2 to 3 days, you should be able to get the patient into your clinic within a day, right? Most of us can't do that, right? But we look at subgroup analysis and try to sort of differentiate drugs on like whether it works within days or a few weeks. Certainly in certain situations, acute, severe, hospitalized UC, that's very, very important. But the majority of outpatients, right? The difference between 1 week, 2 weeks, 3 weeks, and even maybe 4 weeks, maybe not different, right? And this is something that we need to propose to the patients to see, right? If someone says, they're a single mother, they're very, very sick, they need to go back to work, right? Because they have to support their family, then yes, you should probably pick a drug that's predictably in a population the fastest acting drug. But that's usually, so that's a unique case, for example, when you would need a fast-acting drug. I think that what we really need and what's very important is drugs that have sustained efficacy and long-term control because, again, this is a marathon disease. They're going to have it chronically. We want drugs that get patients off steroids, and how quickly they do that is different. We want to heal the mucosa. We want to avoid important long-term outcomes. And we need to remember the importance of the patient in not only the route of administration, but the flexibility in therapy, and we've already touched on safety. And this is again from the UC CARE study, and this is from the patients looking at what they prefer, right? And again, they want drugs that are effective, last for a long time, do work quickly, and are safe. These other things that we do talk about that sometimes we think the patients would value, at least in this study, they were valued less, like route of administration and dosing frequency. And I'm going to just talk about other subgroups. And this is one of the things that does change the way I treat and select therapy. I'm very, very in tune now with and ask about extraintestinal manifestations. And the reason for that is they're more common than we think. Most of you are young, a lot younger than I am. And so when we put in slides like this, where you look at the cumulative, the cumulative incidence of extraintestinal manifestations, is about 50%, with 3/4 of those appearing after the diagnosis. And this is data from the Swiss cohort. A lot of younger physicians say, I don't see that many extraintestinal manifestations. The reason you don't is because you grew up in the era of anti-TNF. And so those extraintestinal manifestations are probably being masked by the fact that they're on an anti-TNF, and therefore, again, but we need to remember that when we're choosing some of these newer therapies. And this is just sort of giving you sort of some of the treatment options when you're looking at extraintestinal manifestations. And if you look at the most common extraintestinal manifestations that we see, whether it be joints, skin, liver, or eyes, aside from the liver, right, anti-TNF in a variety of forms has been shown to be effective in these patients. And if you look at echo consensus statements, when you're looking at specific extraintestinal manifestations associated with IBD, whether it be axial spondyloarthropathy, peripheral arthritis, erythema nodosum, pyoderma gangrenosum, or scleritis and uveitis, anti-TNFs are the recommended therapy there. So that I think is very, very important. And this is a study that we just published looking at this not just from the extraintestinal manifestation, but remembering that these patients also develop other autoimmune diseases. So if you have IBD, you have a 7.5-fold increased risk of developing another autoimmune disease. And this becomes a bit problematic, right? Because this is when you really need to sort of have discussions with your rheumatologist or dermatologist, because some of the drugs that they have and they want to use don't actually treat the IBD, and some people would argue some of the drugs may even make IBD worse. So this multidisciplinary decision making in individual patients who have this subtype of disease with other immune mediated diseases is extremely important. And this is just to highlight some, like at least in the Canadian environment, the drugs that are available to treat different immune-mediated diseases. And you can see that there's many on this slide, including anti-IL-17s, the anti-IL-12/23s, the anti-integrins. But if you want to look across immune-mediated diseases, the drug that has the most predictable response is still anti-TNF therapy. The other thing is perianal fistulizing disease, and this does influence, I think, again, the decision-making process. I don't mean to be critical of gastroenterologists in general when I'm going to make the next statement, but in general, we are very bad at looking at the anus, right? It is remarkable how many patients come to the IBD clinic and have had a fistula for probably 2 or 3 years, like a small draining fistula. They've never developed an abscess. No one has ever looked at their perianal area, right? So only you know, if you actually, when you're in clinic, if you always ask specifically about the symptoms of perianal disease. Whenever we present case studies, everyone says yes and everything, but it's amazing, they're like, oh, we are very in tune of this because it is a common problem. And if you've developed even a simple perianal fistula, there's an increased likelihood that you will have a recurrence or that fistula will be complex. So as soon as you even see a simple perianal fistula, that doesn't necessarily mean they need biologic therapy, but it's more likely that they'll have a recurrence, and that recurrence may become a complex fistula. So again, that will change your decision. That would change your decision making. But really, in general, what the evolution has been is that ability to be very, very comfortable and confident at introducing these therapies early. So this is a slide that I made several years ago, and now I've sort of reused it because I think things are changing rapidly once again with multiple therapies. So this is really the natural course of disease, and when biologics were first introduced, we were using them later and later in treatment, in the treatment algorithm, and certainly we were able to increase disability and surgery when we did that, but around 2010, I think major IBD centers started to use these drugs earlier and earlier, and certainly this has led to improved outcomes, and that was what I was trying to show in the previous slide, not only hard outcomes that we showed in the COM study, but it has a significant economic impact. So the economic analysis of COM has just been accepted in gut and will be presented. And so you can use these drugs early, get the most benefit, and actually it's cost effective. And in some jurisdictions, depending on the cost of the therapy and the cost of hospitalization, et cetera, especially in the advent of biosimilars, right? This paradigm is very, very important. And it will be cost savings, especially when you take into account indirect medical costs. And now many of our patients that we see based on the profiling are actually treated at the time of diagnosis. So that's a bit of insight into how we treat and I think what the potential impact can be. And so when we really think about the right patient, the right therapy at the right time, not everyone needs early aggressive therapy, but you need to be able to identify which patients need that. I think our prognostic factors are still mainly clinical. When choosing that individual therapy, I think you need to think about the risk and benefit ratio in the individual patient, the cost benefit depending on your jurisdiction, those predictive factors of response, and again, patient preference. We need to talk to our patients and think about the individual extraintestinal manifestations, age, perianal disease, other immune-mediated disease. And the most important thing, I think, is really the right time.